Well, good afternoon, everybody. Thanks for joining us today for one of the regular School for Social Care Research webinars, where we present some of the latest up-to-date social care research for discussion and debate. I'm pleased that you've joined us today. My name's Robin Miller, Professor of Collaborative Learning at University of Birmingham and one of the Senior Fellows of the School for Social Care Research. So we've only got an hour today, sadly. I think we could easily spend the afternoon debating the fascinating topics we're going to cover today. And the focus is on delayed transfers of care. And delayed transfers of care often comes up as a hot potato in terms of health and social care policy in relation to inefficiencies of use of the very expensive healthcare resource that is hospitals and some of the tensions that we sometimes get between the health and social care sector. But of course, somebody leaving hospital after a time of crisis is much more than that. It's about potentially somebody losing their independence. It's about somebody going back to their informal networks, and will those networks be able to cope? And it's about somebody's quality of life and future aspirations. So I think it's fantastic that the School for Social Care Research have both funded the research we're going to hear about today and also given us a chance to hear from the presentations. A few housekeeping things. First of all, as ever, if you can keep yourself on mute unless you're actually talking, that would be great. We are planning to record the session. If you are, and clearly unless you speak, you won't actually be recorded saying anything. If you do say something and you're worried about what your recording will be, then please get in contact with us and we can help you out with that. If you could write questions in the chat function, that would be fantastic, and I will pick up the questions that have been posed at the end of each presentation. If you struggle sometimes to write quickly enough in the chat function, raise your hand or try and grab my attention a different way, and I'll try and give you an opportunity to ask your question. Probably the biggest thing we've got is very short in time, so we've only got 10 minutes per presenter, so I'm going to keep them to task in that, and then we'll have 5 minutes for questions, and we're looking to try and finish by 2 o'clock. So hope that makes sense as a general format and an overview of what we're going to cover today. And we're going to start with Daniel Roland from the University of Kent, who's going to talk about his work to identify local authorities with an unexplained rate of delayed transfers of care.
Hello, everyone. Thank you, Robin, for the introduction. My apologies for a technical issue. I wasn't able to share my presentation. So we are going to have some help here. So as Robin said, I'm Daniel Roland. I'm a research associate at the University of Kent. And since I'm the first one to present the first bit of our research, I'm also going to provide a brief overview of our project. So we can go to the next slide, please. So the project ran from 2017 to 2019, and the presentations here are pretty much self-explanatory by their titles, and they're going to be presented more or less in a chronological order as the work was done. We started with a quantitative work on an attempt to identify the local authorities and rank them according to their unexplained detox rates, delayed transfer of care. I'm going to explain what this means in a little while. And this is followed by Gintare's presentation on the impact of Vanguard on delayed transfer of care. This came about after a brainstorming session following data collection from an online questionnaire. And next we'll have Kate presenting stakeholders' view on case study sites. And this is the qualitative strand of our work, and there's a lot more in-depth information in there. And last but not least, we have Steve presenting the influence of social care on supply of social care on delayed transfers of care. And also as part of our research team, we had Professor Karen Jones from the University of Kent, Professor Yvonne Burks, and Dr. Kate Baxter from the University of York. So moving on, first, I'm sure that everyone knows this, but just to make sure that we're on the same boat, delayed transfer of care occur when there's a delay in discharge or when or transfer of a patient who is medically fit to leave the hospital. It is an important issue because according to a report from the National Audit Office in 2016, it suggested that detox has a cost of £820 million to the NHS per year. This cost is very likely to be an underestimate as it does not take into account the impact on patients' well-being and the costs with potentially avoidable readmissions to the hospital. And the same report also found that 85% of detox cases occur with people over the age of 65. And these older patients are very likely or particularly vulnerable to develop new functional deficits as a result of prolonged hospitalization, which in turn limits their activities of daily living, which in turn can make social care packages much more expensive. Moving on, we have the main question, the research question that we wanted to answer. Why does detox occur and what can be done to reduce it? So the way we envisioned the project, we had a mixed methods approach where the initial quantitative work would guide the selection for locations to conduct case studies and also lead to further quantitative work. So how do we get to choose which local authorities we want to explore further? We couldn't look at them all, so we needed to select them carefully. We could just look at the tables and look at detox numbers and identify those with high or low number of detox, or even look at a few years and try to identify positive or negative trends in detox. But we would need to control for other characteristics such as population, percentage of older people, availability of social care services. However, even if we control for that, there's still some unexplained detox in our models. Some reason that is not captured in publicly available data that can lead to a local authority having a better or worse performance than expected. So if we were to find these local authorities, we would be able to find interesting places, interesting locations to look further. So with this in mind, we used information from the NHS England, the Office for National Statistics, and the Care Quality Commission Registry, and we set up a panel data set with quarterly data from 2010 to 2016 at the local authority level. So in the next slide, we have our quantitative model, which basically shows that the quarterly number of days of detox from a local authority I at the quarter T is a function of several characteristics plus an unexplained term that we call it U, as in for unexplained. This unexplained term can tell us if a local authority is doing better or worse than expected, given their characteristics that we have identified here. So we included information on demographics, such as population, information on LA structure, such as the size of the local authority and the number of care home beds, and also economic information, such as the job seekers allowance, pension credits, and house prices. We calculated this equation that you see here for all of the 150 local authorities in our data set. And we also estimated the coefficients for each of those control variables, but our main focus was actually on the last term of the equation, on the unexplained days of detox. So in the next slide, we have, based on our results, the sample of the ranking of the local authorities. We have the top 3 and bottom 3 anonymous local authorities with their respective total days of detox in the period and in 2016 only. And also in the last column to the right, we have unexplained detox that is derived from the results from our estimations. So if it is negative, it means the local authority is performing better than expected. And of course, if it is positive, it means the local authority is performing worse than expected. We have these results for all of the local authorities. They are presented here anonymously, so I can't provide much information about them. But some of the local authorities that we have identified in our model were already being spotted by other means as performing well. So our results are somewhat in line with other literature that is already out there. In the next slide, we see a graphical representation of the table you just saw. And the local authorities performing better than expected are located in the lower half, and the ones performing worse than expected are in the upper half of this graph. You might notice that there seems to be a positive relationship with the number of days of detox and the unexplained detox or residuals. So in other words, the greater the number of days of detox, the greater the unexplained detox. We wanted to correct this. So in the next slide, we show a different way of measuring things. So instead of using absolute residuals or absolute number of unexplained detox, we calculated them as a percentage of detox in 2016. And this produced a much smoother distribution of the local authorities, most of them centered around 0. We do have some slight outliers, especially in the upper left quadrant. There is a unitary local authority from East Midlands. And we need to take this with a pinch of salt because this local authority in particular is very small. So any changes in detox, no matter how small they are, they can lead to large percentage changes. So this is not entirely surprising for us. The next slide I will show you, I try to show something. So this is a comparison between both methods, with the LAs performing better at the top of the table and the LAs performing worse than expected at the bottom. On the left, we have the first method in which we calculated unexplained detox in absolute values. And on the right, we calculated them as a percentage of days of detox in 2016. And I wish I was a bit more tech savvy so I could have a dynamic illustration here of what's going on. But the color code, what I want to show is that many of the local authorities that seem to be performing well with one method, they also seem to be present in the table with the other method. So about half of them, or a bit more than half of them, are present in both tables. And that's true for the top performing local authorities, but also the bottom performing local authorities. And I'll already move on, hopefully on time, for the conclusion and in the discussion. What we did here. So the first bit of the research, we tried to identify local authorities that were performing better or worse than expected. And there was something that these locations were doing, something that we could not capture in our data, and were places of interest for further research. And we could divide these local authorities into any way we wanted based on the data. So if you wanted to look only at urban local authorities or rural, or the ones with higher low population, the ones that were metropolitan or unitary or county. So there are several different ways we can cut the data so it fits our desire to conduct research. And we also found that the results were sensitive to our model, but the patterns were there. They were present even though we changed the method and we changed the specification of the control variables. We still got more or less the same pattern. So more or less the same local authorities were coming up as performing well or worse than expected. And finally, this is just the first bit of the research, and it should serve as a stepping stone for the remainder of the project. And this is not just about detox per se, but this method can be used for other qualitative research that is having a tough time deciding where to look because there isn't enough money to look everywhere. So this is just a method to aid this as well. So I think that's it for me. I do believe we have time for questions.
Fantastic, Daniel. Thank you very much. And that was a great start because you were dead on 10 minutes, which was very, very professional. That's great. Okay, so we've got some questions here, which I'll rattle through. And again, if you can keep your answers quite short and snappy, that would be great. So a question from Robin. Why 2016 data?
Sorry, could you repeat that?
Yeah, why 2016 data? Do we know it's stable over time, or why do we pick that year?
Oh, right. Okay. So the data was, the research was conducted in early 2017. So that's when the project started. So in the first half of 2017, we started collecting data. And that's the information that was available at the time. If we were to go back, we could update it with more information, but mainly was the data that was available at the time. We tried to mitigate the chance for something being incorrectly recorded, because you might know that detox can be attributed to social care or to NHS. So we didn't want to have any blame game going on. So we just measure all of the detox regardless of who was responsible for it, as a way to try to reduce any misrecording.
Okay, thanks, Daniel. That's great. What was the rationale for choosing those explained detox factors?
All right. Okay. So the 10 minutes limit was what caught me off guard here, because I don't have time to go through all of the literature that shows that the factors that we selected are indeed related to detox. But I can assure that this was based on the literature that is out there. There's I think some of my colleagues are going to go through bits of the literature, not all of it. So we base our decision on the literature that is already out there.
Okay, that makes sense. Thanks, Daniel. Annette has asked, where was the data drawn from? I think the data that you used, where was that drawn from?
Right. So the detox data we use patients, the number patients day, and also days of detox. Because there was a change later on, I believe in 2017, in the way detox was measured, we focused on days of detox because that hasn't changed until early this year, March. So that's from NHS England, DTOC data. The data on demographics and needs, those came from the Office for National Statistics. So they have several reports, publications on that, and also regarding the availability of social care, we had this information from the Care Quality Commission Registry. They are responsible for collecting data on social care, and then they make not all of their data, but lots of it. They made them publicly available.
Okay, thanks, Daniel. And final question is from Paul, and he asked, what factors are likely to be within the unexplained box?
That's a very good question. I think Kate is going to talk a little bit more about this. It could be a number of things. It could be a different process. It could be a new technology. It could be investments in human resources, or simply rearranging the way the teams work so that they are more effective in reducing detox. So that's the question that we knew we wanted to answer later on.
Fantastic. Thank you, Daniel. That's great. And thanks for such snappy but informative answers. That's great. So now we're going to hand over to Gintare, who's going to talk about the impact of the Urgent and Emergency Care Vanguard on the delayed transfers of care. Over to you.
So hello, I'm Gintare Malisauskaite from PSSRU at University of Ghent. And first of all, thank you for allowing us the time to present here today. And I'm going to talk about the impact of urgent and emergency care vanguards on delayed transfers of care in England. So first of all, as Daniel already mentioned, detox has been a long-standing issue in terms of costs to healthcare system and also to the patient outcomes. One of the possible solutions to detox has always been proposed to be integration of healthcare and social care services, and it's been used to a few different programs already run in the past: Better Care Fund, Integrated Care Pioneers, and New Models of Care Vanguards, that we specifically focused on. So the idea to look into them happened accidentally, as it wasn't part of the project to start with, but since we did promise to potentially look at integration as such, we came about to look at the vanguards. So there's some previous research indicating that integration is potentially a good solution to reducing detox. However, most of the research is quite limited in terms of how much of it is available, and also indicates lots of complications regarding achieving integration. So it's not an easy solution. The way we identified the urgent and emergency care vanguard sites was using the document by NHS England named New Care Models, Vanguard's Developing Blueprint for the Future of NHS and Care Services. So from this document, we found the local authorities that were involved in this vanguard and identify them as the dummy variables. First of all, we looked at all of the 5 vanguards available, but only one of them caught our attention, which was urgent and emergency care. And then we focused our research on that one. So what I'm planning to try answer today, the research question is there a link between urgent and emergency care vanguard participation and detox? So this is a piece of quantitative analysis based on publicly available data, and most of the data used is basically the same that was presented by Daniel so far. And the model used is also very similar. The only main difference is that this analysis includes an additional year of data. So it's also based at local authority level using quarterly data between last calendar quarter of 2011 and last calendar quarter of 2017. And we're estimating a fixed effects panel model where the dependent variable is delayed transfers of care in terms of delayed days. This data is available from NHS England, as Daniel has already said. And then the English average quarterly for detox is 2,755 days for this time period. So we account for the fixed effects in terms of for individual and time fixed effects. we indicate our main variable of interest, be participation in urgent and emergency care vanguards, as a dummy variable, which is switched on, equal to 1 after the third calendar quarter of 2015, when, which was indicated by the blueprint document as the starting point for the vanguard, for this particular vanguard. And this is the list of covariates that already was discussed by Daniel. So in case if you have questions, I can answer them later, but probably not go at the moment. This graph represents DTOC ratios to population, and these are two different averages. So the solid red line is for urgent and emergency care vanguard partner local authorities over the time period indicated, and the dash blue line is for the rest of English local authorities, depicting average DTOC rates. So as you can see, before the third quarter of 2015, both lines can overlap, and there isn't a particularly obvious trend of what is going on, while after third quarter of 2015, there is a huge difference between the two averages, and it's sustained over time. Right, we account for population in this graph mainly because obviously if there's a larger local authority, it will have higher population and higher DTOC rates. So in order to avoid imprecision, we do this. So what we find is that participation in urgent and emergency care vanguard is associated with a large reduction in DTOC rates, which could be up to 40%, 40.5%, or also equal up to 1,063 DTOC days per quarter. So this is a really large number, and we tried to dissect and look at it in many different ways in terms of number of estimations we ran, in terms of time, estimators, covariates used, and so on. And the effect is very solid. The lowest effect that we found was around 28, 29%, but it never went less than that. And it was always statistically significant, mostly at 1% level, and at a few specifications at 5% level. So the effect is definitely there. One of the specifications is depicted here, synthetic control prediction, and it shows the prediction of what would have happened with DTOC rates in those local authorities that were UAC partner sites if they were not UAC partner sites. So as you can see, the prediction is that the DTOC rates would have risen substantially after the point when the vanguards started. One of the possible explanations why DTOC rates rose overall in England is that in the second quarter of 2015, there were substantial cuts in social care funding, which led to increased rates around the country. However, this does not apply so much to UAC sites because the DTOC rates in UAC sites were never experienced as large rises. So we also looked into if it's possible to say that those local authorities that were participants in UAC Vanguard could have already previously had better DTOC rates than other local authorities. However, we found no evidence of that, and there was no statistical difference found between UAC sites and non-UAC sites. However, we cannot say if those local authorities that were selected into UAC Vanguard were not in a better position to start with to reduce DTOC. So one of the difficulties is pointing out what is the reason why UAC Vanguards could have been so effective in reducing DTOC rates, and only one possible explanation that we could find is channel shift modeling tool, which was aiming to make sure that patients end up where they're supposed to be and that there's care packages available even around during the time that they just entered the hospital. So in order to be able to conclude and explain this more, further analysis is needed, both quantitative and qualitative. One route of potential quantitative analysis is looking into accounting for exposure levels to urgent and emergency care Vanguard participation. And there's a lot of different questions that can be covered by qualitative analysis, and some of them will be discussed by Kate in a few moments' time. So there are a few limitations that should be explained. Is first of all, we do not try to claim causality just yet, even though synthetic estimation method is partially suggesting it. Then we could not add any clarity in terms of how vanguards were selected, as we could not find any publicly available information regarding this, which could help specify our models a little bit better. And it's very difficult to isolate the impact of UAC Vanguard to DTOC separately from other integration policies. So we obviously account for that too, but we can't do that numerically. And just a general disclaimer that this research is funded by NIHR SSCR, and the views are ours and no one else's.
Thank you very much, Gintare. Again, a really precise and efficient presentation. So thanks for that. That was dead on 10 minutes again. So Tim Sanders asked a question about, was there something about participating in the Vanguard program that their choice to participate that might have led to the observed effect? But I think you've said already you don't quite know what the selection criteria was enough to be able to rule that in or out.
We even had a seminar related to where we had some of the specialists in the area. They couldn't also tell exactly what were the criteria. They said that there were some criteria, but they were not listed anywhere or available anywhere. And potentially that part of the selection process was almost like a beauty contest. So it's really complicated to tell.
Yeah, okay. These are always very complicated decisions, aren't they? And Catherine Needham asks about, do you have any theories of change as a research team in terms of what you think would have led to these observable differences? So you might not be able to prove them as yet, but do you have any kind of ideas about, kind of hunches about what you think could be leading to the better discharge data?
So I have a feeling that potentially Kate might be better placed to answer this question, as she had more of an in-depth knowledge talking to people in those places as what accounts to their performance. However, this is where we mentioned the channel shift tool, that one of the aims of urgent and emergency care Vanguard, it wasn't only about emergency response to emergency needs. It was also about dealing with those entering hospital, and that basically is making sure that healthcare is in more frequent and better contact with social care. However, there are a lot of different vanguards within urgent and emergency care vanguards, and we cannot account for the specifics of that in our modeling. So it's very difficult to really say what might be the main exact reason here.
Okay, yeah, no, thank you. That's right. And although they had loose labels, those models, there was a lot of variation in between them all, wasn't there, in terms of the Vanguard program. That's great. Thank you, Gintare. And that nicely sets up our next presenter, who's Kate Gridley. And I'm gonna make a bit of a radical change to protocol here. I'm going to suggest that Kate speaks, and then we go straight on to Stephen, and then we have all the questions at the end, because I want to make sure we've got enough time for Stephen's presentation. So we'll go from Kate to Stephen, and then we'll have all the questions at the end. So over to you, Kate. Thank you.
I'm from the University of York. I was leading on the case studies element of this project, and the overall aim of which was to explore local discharge arrangements and causes of DTOC from the perspective of professional stakeholders, so people working within the health and social care system, as well as some independent providers. So this was a multiple case studies approach, and we had 6 case study areas, which were all local authorities, selected on the basis of site characteristics and also their DTOC performance. We were doing in-depth telephone and face-to-face interviews with those people, and we actually did a focus group as well. And I am failing, my screen has, so this is just an overview of the case sites. As I say, we went for a spread of different case site characteristics, deprivation, ethnicity, integration models, that sort of thing. And we spoke to 52 professionals in total. And as I say, we did one focus group as well. So the analysis I'm going to present today actually focuses on causes of delay in the 4 sites that were seeing increasing numbers of detox in the time period specified. Potentially unsurprisingly, the key themes that came out of that were around home care capacity, nursing and care home capacity, and also something about patient choice, patient and family choice, which I'm going to go into in more detail as we go along. So home care capacity, as I say, was a really big issue that came up in all of the 4 sites. And people talked about how inability to get a care package up and running when it was needed reverberated throughout the system like a domino effect. And they talked about how there were these bottlenecks where if care packages couldn't be put in place to take people from the reablement service, and the reablement service couldn't take from discharge to assess couldn't take from hospital. So it was this domino effect. In another area they talked about exactly the same thing, but as a bottleneck. But what I wanted to flag up was that it wasn't just about absolute quantity of providers in the system. It was also about the type of care package that was required. Excuse me. So an example would be that there might be capacity to take 10 patients from hospital who required one visit per day, or 2 visits per day, or, but from an individual care worker. But if those patients all required double-handed, so 2 care workers to visit, and they might be multiple times, might be 3, might be 4 times a day, and they might all be required, all 10 patients might require a visit first thing in the morning, say 9 AM for their medication, then all of a sudden your capacity to take 10 patients goes down to maybe 2 or 3 patients that could come out at that time. Another key area was care at night. One of the areas we spoke to, they only had 1 provider who could provide any home care at night time, and they'd actually tried to recruit their own care workers. This is a local authority, directly recruit them to provide this service, and they'd offered £15 an hour and failed to recruit. So this is obviously one of the big issues. Another one was about geographical spread. So generally there might be a good level of capacity and provision in the area, but the rural areas might not be very well covered, or more wealthy areas where it was harder to recruit care workers. And this issue of recruitment as well, about when it was easier or harder to recruit, came up certain times of year when you were competing with, for example, the retail industry on the run up to Christmas, and also where childcare was an issue for care workers, for example, over the school holidays. Nursing and care home capacity also came up as an issue. But again, it wasn't just about the number of beds available in the system, it was about the match between the types of people who needed to come out of hospital and the sorts of places that were available and the sorts of care that they could provide. So in particular, there seemed to be in some areas a real lack of EMI nursing placements, so elderly mentally infirm nursing placements for people with complex needs and challenging behaviour. And also where people had been assessed to require only residential care, not nursing care, some participants felt there was a reluctance amongst some of the care homes to take the more complex patients. And this is about the need for more staff to manage the needs of those patients well. And there was an issue in some areas about the fact that the standard rate was paid for everybody, despite some people having more needs and needing more staffing or more skills than other people. And these issues are explained here in these quotes. One about us dealing with people, not tins of beans. So yes, you could have beds available in the system, but you can't just place people here and there. They're not tins of beans, they're people, and so they might not, those placements might not be right for them. The other issue around the complexity of patients and there being a lack of incentive for care homes to take them at the standard rate is also illustrated there, where someone's saying, you know, why would they do that? One of the areas we spoke to had actually come up with a new initiative where they were actually funding some care homes to take more complex patients, some additional funding for the first few weeks, and there was also some additional expertise to support the staff in those care homes and the management to be able to manage those patients. But it was a very new initiative, so we don't really know whether that worked or not. The third thing I wanted to talk about was this issue of patient and family choice, and the way that at the time detox were reported, a reason had to be given for why the person was delayed, and there were codes that covered home care and care home capacity, but there was also one called patient and family choice. And this seemed to be one of the main reasons, choice, in some of the areas we spoke to, except that when we kind of dug into that a bit, the underlying root cause for a lot of it seemed to come back to home care capacity and care home capacity. So, for example, if a package of care could not be put in place at the right time, a person might be offered an interim bed instead. But if they declined that, and there might be good reasons for that, and the person was assessed as being able to go home, it would go down as choice rather than a waiting care package. And similarly, if a person chose a care home, but it didn't have any vacancies, or they wanted to go to a particular area and there are no vacancies there, again, if they said that they wanted to wait for their choice, that would go down as choice rather than there being a lack of availability in the area they wanted. And this just illustrates that issue around waiting for a care package. Here they were saying that the code G, which is patient and family choice, was the biggest in their area. And that was because if people were waiting for a care package, they'd be offered alternative provision, and if they turn that down, they would be put down as I say, patient choice. So we just thought it was worth flagging that up because it might be masking some of the what's actually going on. So just to conclude, really, home care capacity was a big issue. In all 4 sites, they talked about it as pretty much the #1 issue. But it was interesting that it was the combination of factors relating to the type of care package required, its timing and location, that meant that even when capacity overall was adequate, delays could still be experienced by particular patients. And then care home and nursing home capacity, similar issues around it not just being about the existence of a bed, but it's the type of bed and whether there was a match there with the person waiting to be discharged. And then thirdly, this issue of patient choice and whether it actually, some of that actually masks a mismatch between the supply and demand in the system. That's me.
Okay, thank you, Kate. That was great. That really helped to kind of bring out some of the dynamics within each of the case study areas to understand what some of the difficulties were around discharging people. So I'm going to go straight on now to Stephen, and then we'll come back for questions for Kate and Stephen after that. So Stephen's going to talk to us about, well, what's the social care influence then on delayed transfers of care, which clearly nicely builds on what Kate and the others have told us.
Yeah, thank you, Robin, and thank you all for listening to our presentations on our research as you eat your lunch this hour. So yes, I'm Stephen Allan from Research Fellow at PSIU at University of Kent, and I'm going to talk to you, as Robin said, on the influence of social care on DTOC. So as the previous presentations, and as I'm sure you all know, DTOC is a long-standing issue with both cost and patient outcome implications. And usually there are a number of reasons behind DTOC, such as previous research has shown, timing of ward round, medication prescription, discharge coordination, and as well as what Kate has just presented in her fascinating presentation about the availability of social care is a major cause for DTOC. So there is previous research on the effect of care home supply on delayed transfers of care, length of stay for England, but there's very little out there about what impact home care in particular has on DTOC. And so that was our key kind of research questions, was what influence does the availability of social care have on DTOC, and in particular, what influence does home care have on DTOC? So the methods, this was a quantitative analysis using publicly available data. We looked at the local authority level in England using data from 2011 to 2016. So this is very similar model to what Daniel and Gintare have presented earlier. So where delayed transfers of care are dependent on a number of social care supply factors, and then demand and need characteristics that could also influence delayed transfers of care. So we were looking at 2011 to 2016. So for this analysis, so the mean level of total patient days of delayed transfers of care was 2,662 for the average local authority. And then our covariates, again, very similar to those used in the other analyses already presented. We looked at the over 65 population because we know that the large majority of delayed transfers occur in that population. And then benefits uptakes were used as proxies for hospital demand and need. And then we've also controlled for LA social care expenditure and socioeconomic characteristics such as house prices and pension credit. Measuring social care supply, our measures of social care supply come from the CQC register of social care providers. So our measure of care home supply was simply a count of the beds in each local authority, which is consistent with previous research. Our measures of home care supply are a bit more complicated. It's complicated for two main reasons. Firstly, because we don't know the size of home care providers. The CQC register data only tells you that they are registered and their location. So we don't know how many service users each home care provider is supplying their care to. So we just had a count. So for our first measure of home care supply, we used the count of home care providers, and we weighted that by the size of local authorities. So that's providers per 10 square kilometres. The second issue is what is the appropriate market for each home care provider. In our first home care supply measure there, where we're doing a count of home care providers in each local authority, we're automatically assuming that our market is bounded by the local authority, whereas in reality, a lot of home care providers will be working in multiple local authorities. So for our second home care supply measure, we ignored local authority boundaries, and instead we assumed that the market size was based on distance to the location of the home care provider. And so our second measure here is count of home care providers within 20 kilometres of the average small area in a local authority. And so we used a small statistical area within each local authority and took the average of, for that average small area in each local authority, what was the count of home care providers that were within a certain range of that statistical small area. And we used different distances on for our market area. I'll present to you the results for the 20-kilometre distance. Just to give you some context of social care supply in each local authority then, for our period of data analysis, the number of care home beds, there was almost 2,700 for the average local authority. The average local authority had 40 home care providers. And when you took into account land area, so home care providers per 10 square kilometres, there are 2.75. And then home care providers per average small area were over 200 within a 20-kilometre radius. And just to give you some context in how social care supply changed over the period of analysis, so from 2011 to 2016, care home bed supply rose by 4%, but the number of home care providers rose by 56%. So it rose massively in that time. So from 2011 to 2016, there are 16 more home care providers per LA on average, and home care providers per 10 square kilometres increased by over 1 in that time frame. Our findings, we found that home care supply did have a significant negative effect on delayed transfers of care, which kind of links into what Kate found for the specific case sites in the qualitative analysis. So in particular, an extra provider per 10 square kilometres reduces delayed transfers of care for different model specifications by around 7 to 8%. And so putting that into some kind of context for actual what does that mean, an extra provider per 10 square kilometres would reduce detox per quarter by about in the region of 200 patient days per quarter. Using our second measure of home care supply, we found very similar findings. It's a 10% rise in home care supply per average small area reduces delayed transfers of care by around 1.8%. And putting that in context, 2 extra providers within 20 kilometres of the average small area reduces delayed transfers of care by around 4.5 to 5 patient days per quarter. We also found a significant effect of care home supply on reducing delayed transfers of care, which is consistent with the previous research, although our level of effect is slightly smaller than previous findings. And we performed a number of robustness checks, which I'm happy to discuss with anyone subsequently to these presentations. And we may get into in questions as well. So we found, well, we know that awaiting a care package in own home or a care home placement are important reasons for delayed transfers of care. And we find that home care and care home provision have a significant effect on reducing DTOC in English local authorities. And we know that this is going to be important for policy, because delayed transfers of care, as has been discussed, has been an important area for policy over time. And so we've shown just how important the availability of social care, and in particular home care availability, is for reducing detox and meeting any delayed transfer targets that may be set. It also raises questions about the appropriate funding levels for health and social care. It's important to know the savings that can be made. And so indeed, going on from this research, we were able to make a tentative suggestion on the cost savings that can be made from DTOC by increasing social care supply. But also we need to bear in mind that that would only be a base saving based on simply reducing DTOC by itself, and would not take into account any secondary savings that could evolve from improved health from discharged patients. In terms of limitations and future research, well, as I've said, the measure of home care supply was tricky. We've been continuing to work on that, but it may be that for future research we could aim to improve the measure of home care supply by looking at workforce, for example, or service users. And then also, what is the appropriate market size for a home care provider? So we have varied that market size in a number of ways to try and make sure that we make sure our results are consistent and are not just based on our market size. And then there's the potential for reverse causation that we haven't controlled for in this analysis, so that delayed transfers of care may have caused available social care supply. And I will end there. So any questions?
Okay, thank you, Stephen. That was great, and you managed to explain some very complicated methodology in a very accessible way, which was fantastic. Quite a few questions in the chat, so and some comments. So do have a look at those at the end. I'll just bring up a couple here. So a couple of people have raised the possibility of using workforce data, such as held by Skills for Care, to try and estimate the local supply. Is that something you looked into, Stephen?
It's something we've worked on subsequently. So I'm still working on the area of home care markets and looking at measuring home care competition. And I can tell you that, yes, workforce would certainly be one aspect of doing that. So I am using Skills for Care data, but I can tell you that our measure of the local authority measure of home care supply we used is highly correlated to workforce levels at local authority level. So yes, that is a great idea. It is something we are doing.
Okay, that's good to hear. Right, I'm going to give this one to Kate. Kate, you're still with us? Yeah. So, so what Paul has asked about: did the research look at repeat discharge of care for the same individuals? And was that something that came up in the stakeholder interviews in terms of people who were being discharged and coming back in, and discharged and coming back in? Was it the same person that was being managed multiple times?
It didn't actually come back. It would have had the potential to come up, see what I mean? Because we asked about all those sorts of issues. But it wasn't one of the things that stood out. That might be about who we spoke to, just thinking about from whose perspective, and we obviously didn't speak to patients themselves. But we, when we talked to discharge teams and people actually from the health and social care side, that it wasn't the thing that they were most concerned about now.
Okay, thank you, Kate. Okay, so I'm gonna post a question to the research team as a whole. In terms of researching social care, what have you learned from doing this project? What would you say? What are the main insights that you've got in terms of methodologies and applying them within a social care context and to address a social care question? What do you think are the main lessons that you would take from that?
Well, I'll start off. I don't know what others think, but from my perspective, I found it extremely interesting to kind of look at the kind of health and social care interface and look at how that works and gaining insight into that and just how closely related and how one impacts the other. It's very interesting to do that. And secondly, from my point of view, was the mixed methods approach to this research. It was extremely useful. As we've seen through the presentations, they kind of set each other up. The qualitative approach and the quantitative approach have both kind of merged together and worked extremely well.
Thanks, and I'd agree. I think it's been a fantastic layering of methods, and you can kind of get a sense that you weren't, some of it emerged as you went through the project, so you were quite flexible but still robust, which I think was really good. So what about Kate, Gintare, and Daniel? Anything that you'd add in terms of your what you've learned about social care methodologies?
Well, I would just agree actually, specifically around that health and social care interface, that not being kind of prescriptive in advance about who we would speak to, but saying that we will speak to anyone involved in the process, and that we were really flexible. And when you get to an area and you find out that actually someone from health does this, whereas somewhere else, someone from social care does it, you know, that didn't matter. We spoke to everyone who was involved in some way, including some people from the voluntary sector and some care home managers and things, so that we got a complete picture. And often we felt like we knew something, and then we spoke to someone else and realized that we hadn't got the full picture. So I think it's really worth taking like a whole systems approach when you look at these things.
Was that quite challenging for you, Kate, when you were speaking to people, because it wasn't necessarily who you thought you'd be speaking to, so you had to try and place them in the system and in their kind of background and their perspectives?
There was a lot of, there always is, isn't there, a lot of describing actually where you fit within the system that is new to you when you come to it. I think a bigger challenge is actually the recruitment in the first place, because you had to get access to multiple organisations, and they all have their different ways of approving you. So you might have approval from the local authority, but you don't from the hospital, and there might be two different hospitals and all that sort of thing, and then mental health as well. And then you want to contact a charity, and they've got their own systems. So it was that more that was an issue, I think, for us on a practical level.
Yeah, okay, thanks, Kate. And Gintare and Daniel, anything you'd like to add?
Well, I probably would just add that it was a really interesting project. It was very fun to be part of it. And some of the findings were really surprising. So the part that I was presenting, no one really expected to find what we did. And this effect is really puzzling, but very intriguing. So we are continuing to research it. And so far it's still robust to even a lot of other different ways of expressing it. So it would be really interesting to find out more about it the way I see it. But just overall, it was a very insightful project.
Thank you, Gintare. Daniel.
First of all, thank you everyone for their comments and suggestions. I really enjoyed participating in this project, and I think it has already been said, but the interaction between quantitative and qualitative work was excellent. I think if this project were to be only quality or only quant, it would miss on a lot of details. So particularly the way Kate's presentation, Steve's presentation reinforce each other's results from different perspectives. That's very interesting. And I think I would like to see more research about it, because going through the data, lots of things are missing, lots of things we don't know, we don't know where to find. But the more information, the more research is out there, the easier it is to try to solve the problems that we are facing.
Thank you, Daniel. And I think what is reassuring from this project is that you were able to get a decent amount of data. Yes, you might have wanted more data, but you got enough to make some very robust conclusions. It just shows that we can do this kind of mixed methods, large-scale mixed method study in social care. So I'm going to draw things to a conclusion there. Thanks again to the team from York and Kent for a fantastic project and also some great presentations. The next School for Social Care Research webinar is on the 17th of November from 1 to 2. And that will be looking at capacity building and be in partnership with the NIHR Clinical Research Network. So thanks for your time. We look forward to seeing a future webinar, and have a good rest of Tuesday. Thanks all for now. Bye-bye.